बड़ी मम्मी, बड़ी मम्मी, बड़ी मम्मी।
Sir, good evening.
Good evening.
Sir, just Preeti ma'am is joining within a few minutes, sir.
Okay.
So Manas, good evening.
Yes, sir.
डॉक्टर कुमार गौरव सर का ना नेम करेक्ट करा दीजिए, सिर्फ डॉक्टर कुमार दिख रहा है.
ओके सर.
तो एक बार रिदम टेली सॉल्यूशन को बोलो, दे कैन डू इट.
Sir, is it okay? Nishan sir.
सर गुड इवनिंग. डॉक्टर आदित्य, डॉक्टर गौरव सर, निशांत हियर आर बीइंग फ्रॉम शिमला.
गुड इवनिंग.
कैसे हैं सर?
बहुत बढ़िया, गर्मी के मजे ले रहे हैं. मेरे नाम का गलत कर दिया, बिल्कुल गुराव कर दिया.
अरे बड़ी मम्मी.
गांव में कदम रखा है, इसकी किस्मत पता नहीं.
सर गुड इवनिंग. हाँ सर, मैंने देख लिया सर. आप श्रेयस के नाम से सर ज्वाइन थे सर. मैं हाँ मैं रिनेम कर देता हूँ सर. आप ओके सर. ओके सर.
मानस बाकी इंश्योर कर लीजिए, बिकॉज मैम कैन ज्वाइन देन वी विल स्टार्ट.
सर लॉगिन इंश्योर्ड है सर.
थोड़ी सी गरम गरम कर दो। बड़ी मम्मी तुम लोगों को बताएंगी। बड़ी मम्मी आलू की सब्जी कब की है? कल। ये आलू की सब्जी नहीं, आलू मंगवाड़ी है। आलू निकाल, प्याज का आलू निकाल।
So I request you please mute your video, mute your audio because Preeti ma'am, good evening. Nishant here.
Hi, hello. Sorry for the
Hello
delay.
ma'am.
Yeah.
No problem ma'am. Actually, till now ma'am, 4-5 doctors have joined. So we are waiting for 2-3. Then we will start in 2-3 minutes.
All right. No
Yeah,
issue.
thank you.
I'm very good evening.
Hi, Gaurav. Can I just see whether I can share my slides?
Yes ma'am. Sure.
बड़ी मम्मी बड़ी मम्मी बस बड़ी मम्मी कर।
Yes. Oh, but okay.
So Manas just confirm about the rest expert now. Then we can. I think we should start because we are getting late also.
Yes, sir. Start, sir, and doctor, all join, sir. Sir, we can start, sir.
Yeah. So ma'am, now I think I should start by introducing you by setting the context.
सॉस दे दे सॉस। अरे यार क्या गधा आदमी है। अरे साफ करके ला।
देख लो साइन करने से पहले।
गड़बड़ हो जाएगा।
और ये क्या है?
वही गड़बड़ हो गया।
मतलब कि
I request to other expert, please keep your audio on mute and you can have your video on.
उसका क्या करेंगे?
So ma'am, should I start, ma'am?
Yeah, please, please.
Yeah. Okay. So good evening all. I am Nishan Chaudhary RBM on behalf of CIPLA. I welcome you all for this Stamping Hard Expert Forum meeting. It's a ad board meeting. So I will request to all the participants as an expert, please, while question answer session, please keep your video on because it's mandatory, and we will not take much of your time because we are already late. So for today's expert meeting, we have our moderator, who is Dr. Preeti Sharma, madam, who is from Max Hospital, Dehradun. Ma'am has done MBBS, MD, DM in cardiology, and who is already having a rich experience of more than 15 years. So, ma'am, now, ma'am, we wish to hand over to you, ma'am. Please take it forward. Thank you, ma'am. Yeah, thank you. Thanks for your presence.
All right. Good evening, and so in today's meeting, we'll discuss regarding neuroreceptor antagonists, a boon in heart failure management. And from this meeting, the insights we're going to gain are the placement of MRAs and utilization in heart failure management, and our common fair physicians practice, and just to create awareness among physicians on mineral receptor antagonists. So as we all know, sorry. So as we all know that if you look at the prevalence of heart failure, this is 26 million people worldwide, and 1 to 2% of adult population with heart failure are there in developed countries. And we all know that the prevalence increases with age, and it rises to more than 10% among people more than 70 years of age. So if we talk of India, around 1% of total population, or so if we talk of prevalence of India, around 1% of total population, or around 8 to 10 million individuals. If you look at the annual incidence, it is 0.5 to 1.8 million new cases per year. 0.1 to 0.616 million individuals every year is the mortality. So now I open this discussion by asking you that in your practice, what is the percentage of heart failure patients who approach you in NYHA 2, 3, and 4? And how many heart failure patients they go undiagnosed in India at an early stage, and why? And the second question we are taking is what are the diagnostic and prognostic tools we use in our heart failure patients? So if we can discuss, so I have to stop sharing, no? Then. So yeah, so if we can discuss this question, so I invite our experts here in the panel who wants to take up these questions, and then maybe we can take up another slides.
I'm Dr. Vyas. Mostly the patients of heart failure we see, they present with us in NYHA 2 or 3 or more. All of them, because maybe it is because their first presentation to the clinician. And what was the second question?
So what are the diagnostic tools we are using in these patients, and what do you think, why these patients are presenting to you late, and why we don't diagnose heart failure in the initial stages in India?
Because in my opinion, one of the common factors is that they just take their breathlessness due to some other factors, maybe because they think that it is due to weakness and all. I mean, they present late to the clinics, and maybe sometimes they have a certain, I mean, other illnesses also. So they confuse, so they get late in presenting to us. That's it. Something wrong. I guess we have lost some connection.
No, actually, ma'am is there. Yes, you will connect.
नहीं हुआ, बुला लो ना, बुला लो।
Actually, ma'am will join soon because I think
बहुत यहाँ पर 4 हैं.
we lost her, so she will connect soon with their network issue.
Dr. Rajinder, here lot of background noise is coming. I don't know other
Actually, the noise is coming from Dr. Aditya Gupta sir. So request you sir, please keep your audio on mute.
A lot of background noise is there, so it's causing a lot of problems.
Sir, I think now there is no background noise. So already told to Dr. Aditya sir.
Yeah.
Can I share my screen again?
Yeah, sure.
So what my perspective is that why do we diagnose these patients? Because most of the time when they are these patients are going to our physicians, the basic tests which are mandatory once you have a patient who is presenting to you with dyspnea, edema, just try get an ECG, echo, X-ray. So they should be the basic tests. I won't say that you should do NT-proBNP in each and every patient, but these are the basic tools which actually gives you idea about the diagnosis of this patient. And the earlier you diagnose, the better you treat, and more is a better results in these patients. And prognostic tools, what we use is most of the time we go by the important prognostic tool, I would say, is the NYHA class. And then by echo, you can, ejection fraction is the most prognostic tool which you use in your patients. And then comes your patients' arrhythmias, which NSVT runs, and they trouble your patients and they can cause sudden death in your patients. So these are which commonly as cardiologists we see in our practice, and how a patient is actually responding to your treatment. Like once you have started them with the guideline mediated therapy, how is the response, whether they are able to tolerate. So the people who are able to tolerate medications without having adverse side effects are definitely going to have a better prognosis rather than the patients who are not tolerating these medications. So these are my perspectives. And according to 2021 update, ACC update, so the decision pathway for optimization for heart failure treatment, it says that the caution should be exercised when mineral receptor antagonists are used in patients, and the serum potassium concentration is more than 5, and if there is a severe renal impairment, which is EGFR of less than 30, or creatinine which is more than 2.5 in males and more than 2 milligram per deciliter in women. So obviously we all know that we are more careful once we have this kind of population in our heart failure management. And are these parameters, so the third question is that are these parameters tested before and after initiating MRAs, and how long? So I want to take a poll. How do we proceed in our patients? Like whosoever wants to answer this, we can just discuss about this. That once we are writing these medications like diuretics and ARNIs, and how do we manage these patients regarding their these parameters? So whosoever wants
so
to, so we can.
Once we start these drugs, we get a baseline creatinine and potassium to be repeated after 4 to 8 weeks again. That's it.
All right. So definitely in all these patients, heart failure patients, these are basic tests you do. For me, CBC is also important for me, and RFT, LFT, thyroid profile, and if iron studies. So these are important things we all should be doing in our patients when we are managing, because if hemoglobin is low, your patient is not going to respond that optimally unless and until you. So this is now a class 2A recommendation, correcting their hemoglobin and correcting anemia and giving intravenous iron. And once you want to write, so suppose you are writing with a loop diuretic along with an MRA, and you are giving ARNI, you have to be careful in initial few weeks, and you have to tell your patients that they have to avoid high potassium diet. Otherwise, these, and specifically in incipient nephropathy patients, diabetic patients, you have to be more careful in telling them that these medicines can give rise to high potassium. So they have to take care of the dietary part of this. No indulgence in coconut water, too much of coconut water or fruit juices. So this is commonly we face in our day-to-day practice, that these are the simple mistakes our patients do and they'll end up with high potassium. And then we have to withdraw these important medications from their treatment algorithm. And I would say that if I'm writing this medication, sir has nicely mentioned that I would want to call them back at 2 to 4 weeks, go slow, and just follow these patients once every month. And maybe once every parameter is settled, you can follow these patients every 2 or 3 months. So this is how I think we all are practicing while we're writing these guideline mediated therapies. So HFrEF, it is recommended to reduce the risk of hospitalization and death. MRA, it is a class 1. And if we talk of heart failure, mildly reduced ejection fraction, it is class 2B. It can be considered to reduce the risk of hospitalization and death. We all know that heart failure, mild reduced ejection fraction is still, we do not have any tool which is class 1A. Rather than managing their comorbidities, managing their diabetes, high blood pressure. And now we have one positive trial with SGLT2 in this group of patients, HFpEF and heart failure modules, mild reduced ejection fraction. So we all know this is the very commonly seen slide we all see in our presentations. So how to manage these patients? Now 4 pillars of therapy to reduce hospitalization and death is ARNI, beta blocker, MRA, and SGLT2. And if your patient is volume overloaded, diuretic, once the lungs are dry, you can add beta blockers in this patient. This is how we do in our patients. And if it's still symptomatic, you have a patient of CMP, cardiomyopathy, who is having LBBB and a QRS, which is more than 150 millisecond, and is sinus rhythm. Then CRT P or D, depending on the comorbidities of the patient. If it is ischemic etiology and the QRS is narrow, then one can consider for ICD. In non-ischemic etiology, ICD is still class 2A. And if your patient is having AF, then anticoagulation, we all know. And if your patient is having coronary artery disease, then you have to revascularize this patient. Iron deficiency, we have already discussed. And if aortic stenosis patient with heart failure, these patients are now better managed with TAVR. And MR, one can think of, in few specific patients, you can think of repairing mitral valve. And still on guideline mediated therapy, if these patients are having a heart rate which is more than 70, in sinus rhythm, you can think of adding ivabred in this patient. And in black patient, in some patients of CKD, while they are not tolerating ARBs and all, hydralazine and isosorbide dinitrate, they give you good results in this group of patients. And once your patient is in class 4, for selected patients, you can think of MCS, and some of them can be candidates for heart transplant. And in this group of patients also, exercise rehabilitation and multidisciplinary treatment. So this is how we manage these HFrEF patients in today's scenario, and these are the what the guidelines says. And I'm sure all of us are managing our patients like this only. So now again, I'm going to ask you a question: what percentage of your patients you are using mineral receptor antagonists? And when do you consider starting MRAs in patients along with ACE/ARB and beta blocker? So we can discuss the first question, like in what percentage we are using MRAs in our heart failure management. Dr. Rajendra, Dr. Gaurav.
Yeah. Ma'am, good evening. I'm Dr. Rajendra from SMI. So regarding percentage, I think if we specifically say in patients of heart failure with reduced ejection fraction, after giving ARBs, ACE inhibitors, or these days ARNI, followed by adding the beta blockers. And if patient is still symptomatic, I think we have no choice but to use MRA. And provided the things we have ruled out, that contraindications like hyperkalemia and the EGFR less than, if we have calculated the EGFR, so if EGFR is less than more than 30 and patient is still symptomatic on ARNI and beta blockers, to the maximum titrated doses we can use, I think we have no option but to add MRA in all these drugs, all these patients.
So anyone? So I would say, yeah.
And
so I would
most of
say
the patients
that, yeah. So I would say around 30 to 40% of the patients you are able to use once you are using loop diuretics. Along with that, if you are having hypokalemia, And so you have to see once with a loop diuretic and ACE and ARNI, how is the potassium like? So whether you have a liberty of using. So the idea of using this is only keeping potassium in check so that you can actually avoid having arrhythmias and sudden death in this group. So this is how this drug actually helps you. We will see the mechanism in coming slides also. So when do you consider starting MRAs? We've already discussed. Once you are giving a diuretic, ACE ARNI, a beta blocker, and your patient is tolerating, urea creatinine is all right, potassium is on the borderline or low, then you can add MRA in this group of patients. So I think most of the time you are able to use this medication along with the other pillars of heart failure therapy. And yeah, you want to say something, Dr. Rajan? I think you were saying something.
No, I was just.
So aldosterone-scape in congestive heart failure. So importance of time of initiation of mineralocorticoid receptor antagonists on risk of mortality in patients with heart failure. So you should use MRAs as early as possible on top of treatment, including ACE, ARB, and beta blocker, preferably at the discharge after an episode of decompensated heart failure. So I would again emphasize, it is better that you start these medications in hospital once your patient is stabilized, because that is the best window when you can give this medication and you can actually see the results. If you think that you will start it in your OPD, then the time is gone. You'll never be able to do that, or you will delay the therapy. Following an acute fall in aldosterone in response to administration of ACE, the level of aldosterone rises again and indeed returns to baseline in almost all patients, which is known as the aldosterone escape. So even when an ACE inhibitor is given in combination with an ARB, aldosterone level remains uncontrolled, and this might promote release in angiotensin II via positive feedback loop that stimulates in the vasculature. And the progressive escape of aldosterone are thought to contribute ACE inhibitor resistance. So whereby the effect of ACE inhibitor become blunted and beneficial effect of mortality decreases over time, where the MRAs are able to antagonize the deleterious effect of aldosterone, resulting in beneficial effect on patient mortality. So we should all try and use all the 4 pillars and in judicious manner in all our patients. So this slides actually gives you the rationale why. And if you want to compare, you have 2 aldosterone antagonists. One is a spironolactone, another is the eplerenone. And this is a study of 224 patients of chronic heart failure with HFrEF in NYHA class 3 or 4, who were selected by random sampling from 2017 July to June 2018. And these patients were given either spironolactone or eplerenone. And each patient was evaluated clinically, biochemically, and echocardiographically at the beginning of the treatment, and at 1 month, and at the end of 6 months. And echocardiography was performed to find out change in LV systolic function. So as we can see that in spironolactone group, if you see at LVID baseline 61.3 at 6 months 60. So so in this patients 5.3, 61.3 patients, initially 5.3 and then 4.5, and mean of difference is 0.8. And in eplerenone group, this baseline is 5, and then 6 months it is 4.9. So mean of difference is 0.1. And if we look at the end systolic volume, the mean of difference is 16.3, 1.9 in spironolactone group, and it is 6.3 at the end of 6 months in eplerenone group. So this is the comparison which actually gives you so this study was designed to compare both the things. And just to know, this is eplerenone is a selective antagonist, and this is expected to have a lower incidence of hormonal side effects than spironolactone. So this is the result of this study, and let me open forum and we can discuss about when do you prefer using eplerenone and spironolactone, any specific patient profile. So if anybody wants to take up this question, we can discuss about this. So any specific choice regarding spironolactone or eplerenone? So in my contention in diabetic patients, this has been shown that eplerenone has benefit over spironolactone. So most of the time, if a patient is affording, and I tend to use this molecule in this group of patients. If anybody have a different experience and want to share, then we can discuss regarding use of eplerenone and spironolactone.
I think
Anyone? Yeah.
I think we have no second thought that eplerenone is better than spironolactone as shown in the previous study also. I think we can prefer eplerenone in male patients compared to because spironolactone cause gynecomastia and those. So
it is hormonal side effects are more with this. So it is the cost sometimes can become an issue for a couple of patients, but definitely this is a better molecule. And spironolactone and eplerenone, we all know that if the EGFR is more than 50, then spironolactone dose is 25 milligram per day. And if it is 30 to 49, spironolactone dose is 25 milligram every other day. And in eplerenone, the EGFR more than 50, then you can give 50 milligram. If it is 30 to 49, you can give eplerenone 25 milligram per day. And regarding potassium, if it is less than 4, you can increase the dose from 25 to 50. And if spironolactone dose is 25 every other day, then if the potassium is low, then you can increase the dose. And if it is 4 to 5.4, no adjustment required. If it is 5.5 to 5.9, then you have to decrease from 50 to 25. So this is how we all manage this in our practice. And if the dose is, so eplerenone, you can reduce from 100 to 50, and then 50 to 25. We all know, we all do all this. And if it is more than 6, then you have to stop MRA treatment and release and reassess the potassium after 1 week. And once the potassium level is less than 6, initiate a K binder and reintroduce MRA. So this is how you should manage and monitor these patients, and stop MRA in any case if EGFR is less than 30, and reintroduce upon clinical decision upon the renal function improvement and potassium stabilization. So if your potassium goes more than 6, then definitely you need to stop this and reassess your patient after stabilization. So again, we can discuss about what is the preferred dose in our practice and how is the dose titration is carried out in our practice. So anybody wants to answer this? So we can go ahead, like we can take up Dr. Toma, Dr. Gaurav, anybody wants to take up this question, and we can discuss regarding how. So preferred dose, I would say it is 25 milligram, and then I will reassess my patient. I will check their potassium levels, and then I'll increase the dose as the slide mentions. And if we look at the MRA related hyperkalemia, the prevalence of hyperkalemia was 9.3%, out of which 54% was truly related to mineraloreceptor antagonists. So this is in all the trials, this has been seen that this is the incidence, this is the prevalence of hyperkalemia in patients who are treated with mineraloreceptor antagonists. So again, what percentage of heart failure patients on MRA develop hyperkalemia and require discontinuation of treatment? So if we can have poll from the expert panel, what percentage of patients you have to discontinue MRA in your practice? So Dr. Rajan, you want to, because if Dr. Kumar is here or Dr. Gaurav is here, yeah, Dr. Sharma, please. Yeah.
I think ma'am, who is left, they can answer.
So ma'am, I think in our clinical practice, we don't see much cases of hyperkalemia, and I think all of us, all the clinicians, most of us are using this spironolactone and eplerenone with loop diuretic. So because we are using combination, so hyperkalemia is very, I think percentage is not more than 2 to 3% of the patients. I found very less patients in my experience. If we are using loop diuretic with the MRA antagonist, so the cases are very few, though they do come. And I think in previous slide you have shown that up to 5.4 we can wait, but I think in our setup and the way the patients are from periphery, I think we should be even alerted at around 5 only. We can consider stopping then waiting to cross 5 in our setup. And the incidence is really low when we are using with loop diuretic.
Definitely, one thing I would say, yes, the hypokalemia incidents are somewhere around what we have seen in the slide, up to 5 to 10%. But the percentage which needs to discontinue is, I would say, I would rather reduce those unless and until it goes more than 5.5. Because we have seen the reason it is an important drug for heart failure management. So if potassium is more than 5.5, then only think of discontinue. The others, the slide says more than 6. So I have my threshold at 5.5. And below that, between 5 to 5.5, I would rather manage these patients by reducing the dose of this medication. So if anybody wants to add their opinion or their practice, how they manage these patients, then otherwise we take up the next slide. Yeah. So this is, we will discuss in this slide about the EPISIS trial, the timing of eplerenone initiation and outcome in patients with heart failure, acute MI complicated by LV systolic dysfunction. And in this study, there were approximately 6,000 of the patients which were enrolled from day 3 to 14 after index AMI with a median of 7 days. And around 3,319 were assigned to eplerenone, and then they analyzed the effect from time to eplerenone initiation versus placebo based on the median time of initiation of treatment, earlier or later, and effect on outcome were evaluated. So the conclusion of this study was that earlier eplerenone administration between 3 to 7 days post AMI actually improved outcome in patients with LV systolic dysfunction and heart failure. And this benefit was not observed when the eplerenone was initiated later, more than 7 days. So this is a trial which actually tells you once your AMI patient with heart failure is admitted, and then in these patients, it is better to start these MRAs early in the treatment to give them good mortality benefit rather than starting them late. So this is the 31% reduction in all-cause mortality in patients with heart failure post-AMI by eplerenone as compared to placebo when initiated before 7 days or after 7 days. And 34% reduction in sudden cardiac death was seen. So I was telling you this is the mechanism how it helped these patients if you start them early as compared to you start them late. So in your clinical practice, so this again a question I'm taking up. And in clinical practice, how early are MRAs initiated for management of heart failure patients? So Dr. Aditya Gupta, I can see you if you want to answer this question in your practice. How do you follow these patients, and how early you start MRA in your patients? Dr. Aditya, if you want to take up this question. Dr. Tomar, I could see that you were interacting initially and then you had suddenly gone. So if you want to interact and answer this, so I think
I think if Dr. Tomar is asking, then
I don't see it. Yeah.
So I think in previous slide only you have shown that in patients of MI, as early as we started, we get the benefit. So if heart failure is associated with ischemic disease, it should be started as very early, within 2 to 3 days. And if we have heart failure related to cardiomyopathy, then as we studied in the previous slide, that using ARB, ACE inhibitors not responding, then ARNI, beta blockers, and then we can add mineralocorticoid. So if ischemia is the main
idea is earlier is the better.
Yeah.
Earlier is the better. And you should check their potassium and their urea creatinine. So this is again, we are at the same slide, 4 pillars, ASRD, beta blocker, MRA, SGLT2. And if there is volume overload, then loop diuretics. This is all class 1. And if patient is in sinus rhythm, ejection fraction less than 35 with a QRS which is more than 130, you should consider these patients for CRTD or P depending on the comorbidities of these patients. And in patients who have QRS of more than 150, CRTD is a class 1. In 130 to 149, it is a class 2A. And in ischemic etiology and ICD, narrow QRS, ischemic etiology and ICD is class 1, and in non-ischemic it is class 2A. And if symptoms persist, then you should proceed to the class 2A recommendations. So again, I'm taking this poll: at what stage of heart failure diuretics and MRA both are needed? And what is the preferred choice? Eplerenone plus torsemide, eplerenone alone, spironolactone plus torsemide. So at what stage we use both these therapies in patients? They are needed. So I would say any patient who is having a clinical heart failure. So these are the patients in whom you want to use both these therapies. And if so far my therapy of choice is torsemide plus spironolactone, but definitely after presenting this, it might become torsemide plus eplerenone. So it depends on your doctor's preference, and sometimes patient preference also. And we have seen the data that this is a better molecule and gives you a little better results if you compare it with spironolactone. So any other thoughts on this? Most of us, I think, with that. Yeah, please. Yeah.
Ma'am, I think heart failure class 4, I think refractory heart failure, we need to add both diuretic and MRA. In class 2 and 3, we can just use because the loop diuretic doesn't have much mortality benefit. So I think in class 2 and 3 we should use MRA only. What is your opinion? In class 4 we have to use loop diuretic. There is no choice in refractory heart failure. But as far as class 2 and 3 are concerned, I think if we use MRA only, that is more beneficial and give the maximum dose if patient tolerate. Is there any benefit of adding loop diuretic in class 2 and class 3?
So it is about if your patient is congested, is having pedal edema, and this patient might be in class 3, not necessarily class 4. So these patients, if you see that there is volume overload, you have to give them loop diuretics and then MRA also. And I would say if you feel that patient is not volume overloaded, then you can use MRA only. I would not go by the class. I would go by the wet or a dry patient. If it is a wet patient, lungs are wet, there is edema, I would use loop diuretic to give to decongest this patient. And then if the patient is not that volume overloaded, I can keep this patient on MRA only. I'm happy with MRA. So this is how I would manage these patients. So class 3 patient can also have edema and congestion in the lungs. Not necessarily will present to you in NYHA class 4, like dyspnea at rest. He might present to you with dyspnea on minimal exertion, less than ordinary activity. So this is a class 3 patient who is volume overloaded. So you might have to give them loop diuretic to give them benefit. All right. So this is the last slide. So do you have any other indication in your clinical practice where MRAs are used apart from heart failure? So I would say in my practice, MRA, specifically spironolactone, I would use in my patients of resistant hypertension, because this is we know that these patients, mostly these are primary hyperaldosteronism patients. And this is a good medication for resistant hypertension. So I would use spironolactone in patients in whom, after adding 3 or 4 drugs, the patient is having an uncontrolled blood pressure. So sometimes this drug acts like wonders and gives you BP control, which is not being achieved with any other medication. Apart from this, if anybody has any other, have used it for any other indication, then we can discuss. Yeah. So I think we come to an end, and thank you very much. We are really late in this session, but so if any other thing we want to discuss, or if anyone from CIPLA, they want to share any thought on this, then. Hello. So I think we are good to go, Dr. Sharma, Dr. Tomar, Dr. Awasthi. I think any other thing you want to add to this discussion, or we can, I mean, it's quite late, so we can just say good night and a good note.
And we thank you, ma'am, for putting.
Thank you, ma'am. Thank you, ma'am.
Bye-bye.
Thank you, sir, and thank you, ma'am, for participating in this meet, ma'am. And thanks a lot, ma'am, sir, and ma'am.